So we want to make sure that this kind of is tailored to kind of what you want to learn about. The things that we were asked to kind of train about was these particular screening measures. So how many of you already, so that we know how much time we need to spend on each of these, how many of you already have been doing the ASQ3? Like historically, like you've been doing it prior to maybe August 1st, that it's not something new? So a couple people. Okay, this is different than yesterday. This is what I asked. How many of you have been doing the ASQ-FE? This is where like it's really helpful if everyone's raised their hand because I'll go slow and I don't want to go slow in this section if we don't need to go slow. How many people have done the MCHAT prior to this contract year? Okay, this is your first time? Okay. And what about postpartum depression screening? How you used to do that? Okay, so we have some folks there. What we really like to do is make sure that we're utilizing the expertise in the room. You know, this Miami-Dade is such a diverse population. There's so many different ways that we can interact with families. There's so many different resources. So if we say something, then you're like, well, what about this resource or this resource? You know, it'd be great if you'd be willing to share that with the rest of the group. Let me ask you, so why do you think people do screening at all anyways? Like, why do we do this? I mean, it's really just to create more paperwork for y'all, right? Like, why was screening even invented? Right.
Sometimes because they know it, the child that they know
so the parents' expectations for where the child should be may not actually match where the child actually is. The other piece is that with developmental screening, you can't always just observe and determine just by looking at a child or talking to a child that they might have some additional needs. You can't always just by, you know, pediatricians asking parents questions. You can't always, you know, find out whether or not there's an additional need for additional assessment, right? We all come in with our own biases. We were all raised by our own parents in some particular way that, you know, impact how we view the world. And depending on kind of where you're coming from, so like if you're a pediatrician, you're looking for certain things. If you're a home visitor, you're looking for certain things. You're a psychologist, a social worker, a teacher. You're all looking at maybe a little bit different areas of development. So depending on how you're looking at the same thing may impact it. And how many of you, like, you 100% trust everything that your parent tells you? And sometimes it's not like that, yeah, it may be that they just don't know, right? Or it's something that they haven't observed. And Nancy will show a perfect example of that a little bit later with the video. The other piece why it's really important to screen is just by asking questions or observing, that you can usually tell this group that is clearly like a typically developing child, and there's kids that you see like, something seems to not be quite right, and I don't know what it is, but it probably warrants further investigation. But what ends up happening is if we don't screen, we miss out on kind of that middle group, that under-detected group. So those folks in the middle, that if we didn't screen, we're not catching these kids, and maybe they fall through the gaps. So it's really important that if we have systemic developmental screening, it actually helps with that process. So we're breaking into different groups of, you know, the process is when we're screening kids or we're screening parents, there's going to be ones that are not near the cutoff. Depending on your program, maybe you're continuing to monitor that over time. Or maybe they're providing them like, hey, you're doing an awesome job. Your kid's exactly what they're supposed to be. You keep on doing those excellent things that you're doing. If they're near the cutoff, maybe that requires some level of monitoring. Or maybe there are some other complicating factors that make you think that, well, you know, the fact that they're near the cutoff and we know that the child has this genetic condition, it might make sense for us to go ahead and make that referral to the next place. Or if they're above or below the clinical cutoff, we clearly want to move them to that diagnostic stage. We know that there's a pretty good safety net for kids 0 to 5. Older than that, you know, there's a lot of, you know, public schools. There's a lot of parenting programs that are serving kids older than that as well, depending on what we're actually screening. So to the degree possible, we want to be connecting kids with further evaluation or parents with further evaluation when indicated. All right, just because I get sick of listening to myself talk, I will throw in some videos occasionally. This is the developer of ASQ3.
Screening is a quick look at a child's development to see whether their behaviors are occurring as we hope they are, or whether there might be some delays or some concerns parents have. So screening is really the key to early identification, to getting help to a child as soon as difficulties might occur, and to helping to make sure that that child has optimal developmental outcomes.
All right, so that's Dr. Squires, who was one of the developers of the ASQ3, helped with the ASQ2. So we're going to get into just jumping right in, kind of talking. Raise hands again if you feel like you're pretty solid on administering the ASQ3. Okay, all right, so we're going to walk you through that process. Again, we just want to make sure that everyone feels good about where they're at. And again, it's not always something that you're like at the end of the training, like, well, I got that piece, but that other piece, I wasn't 100% sure on. We're going to make a lot of the tools, so like this entire PowerPoint, we're going to provide that to you. Both Nancy and myself, we will make ourselves available. If you want to contact us, if you have specific questions, and to the extent that we can help, we will be more than glad to do that. You like how I volunteered Nancy without her permission right there? All right. Nancy, go for it. All right, how are you?
Okay, so ASQ, basically what this is a developmental screener. This does not diagnose any type of delay, any type of condition. It's just a screener to kind of guide the parent of what their child is developing and what their child is able to do. It has questionnaires available from ages 1 month to 5.5 years. And like we said, it's to identify for children who are at risk, not to diagnose. There are 5 different domains that they test: communication, so the expressive, receptive part of communication, their gross motor, how they're using their bigger muscles, how they're walking and crawling and sitting up, fine motor, how they're switching from one hand to another, how they're using a writing utensil, problem solving, personal and social. Okay, everyone should have a copy of an ASQ. Do you have an agency? Okay. Questionnaires are, like we said, from 2 to 16 months. They're spaced 2 to 3 months apart, so we're able to administer them very frequently.
And just to be clear, the later ones are spaced 6 months apart, but again, when you see at the top of the ASQs, it will actually list what age range that particular form's for. So again, between 1 month to 60 months, there's the opportunity to screen them. It's just a matter of making sure that you pick the correct one.
Okay, so that's exactly what Jason was saying. For example, up here where you see 16 months, you're able to give it as early as 15 months and as late as 16 months and 30 days for this particular syndrome. It has a space for you to complete the date that you complete, the administrator of the ASQ, their date of birth, and it's also asking if they were premature. So the reason it's asking you that is because if they were preemie, you need to correct their age in order to administer the correct questionnaire. Okay, and we'll go over that too. You only need to correct their age until they're 2 years of age. After that, just use their regular chronological age. Inside, just to go over it, you'll see the 5 different domains. Each domain has 6 questions. Each of the areas has answers that they can provide. It's either yes, sometimes or not yes. Questions 5 and 6 are usually average skills of what a child can do for that age. Written in 4th to 5th grade level, so a parent can understand easily. It's available English and Spanish. We don't have Creole yet. We're hoping for that soon. Unscored section. If you go to the back, page 5 and 6. These are questions that are not scores, questions that may be of parent concern. So questions like any concerns with hearing, vision, any medical conditions, anything that the parent might be concerned with.
And that's really important. So, like, for example, a child may pass in the communication domain, but maybe in that section, the parent reports concerns about their child maybe stuttering. So even though they pass in that domain, it would still warrant potentially an additional referral. So it's important to make sure that you're administering the whole thing so that you make sure you have that opportunity to actually get additional information. Because those parent concerns above and beyond just looking at those domains, if they're reporting concerns, are actually predictive of developmental risks or, developmental delays.
Okay, and in the back is your summary sheet. This is where you would report the scores and any concerns that the parents have. And it also has a great graph where you can actually show the parent where their child's score lies in, and what you can do for follow-up, or what is your next plan with the family. Okay, so the fun part, how to administer the ASQ. All right, first and foremost, obtain consent from the parents. You have permission for them to either them complete it, because the parent can complete this themselves, or you can administer it with them. You can ask it interview style, or you can actually use the ASQ toolbox. And basically what that is a bunch of things that you can do activities with. These are things they have the list in the ASQ site. You can get a list of the toys that they actually use, and you can go to Dollar Store and purchase them, or your program can actually order it from the on site in the ASQ site. Next, explain the purpose of the questionnaire. Once parents are really scared when you come with this form and you're like, okay, let's fill this out, they want to know what this is for. To explain to them, this is, for the benefit of their child. You want to see how, little Susie's doing, and this will determine if any services are needed afterwards. Schedule the screening, so either how you do it in your program, by phone, by in person, in a well-child visit, at a home visit. Select the ASQ, the correct one. Remember, for prematurity, we have to correct the age. And let's see if demo materials is needed.
So just to add, and Nancy kind of alluded to this a little bit, and we know that we have different providers. So home visiting programs, like you're going, I'm assuming, some of the time, perhaps most of the time, you're seeing the parent and child together. There's probably some group, so that there is that opportunity where you could use the kit. You have that opportunity to really teach the parents about all of the wonderful things that their child's doing. Nancy's going to demonstrate that in just a minute via video. But it also is something, so there's probably group parenting programs here, or the group parenting programs where the kids are not even present. So you can't use the kit quite as much, or you can't necessarily have that opportunity for individual administration. It's still a valid measure to be handed to the parents and they fill it out. Sometimes it does require you to follow up if you feel like what they're marking isn't necessarily accurate or you need some clarification. So that's just something to kind of keep in mind. But we wanted to make sure that you understood kind of like what ASQ could actually be if you actually have that opportunity to really work through the kids with the family. So Nancy will chat you through this.
One of the basics that we're going to be on the ASQ and get us into development, make sure that everything's on target. What is this? You have to try to reach for it. Usually at this stage they don't really reach or they don't grab it, but she does have to do well. So this is our well. We administer agency agents in the well-child visit at the pediatric hospital. So this is Angel and we're administering the form of ASQ. Now I have the opportunity to use the material. And the reason I have that, Mom was okay to fill it out, but sometimes Mom was marking that she couldn't do certain things. And the reason she was doing that is because she never did a
mention it, or she doesn't have the materials at home. So me and my handy box went ahead and grabbed onto the bottle and was able to do that. And was able to show mom, I can do this. And she got excited for doing that. And at the same time, you're educating her. It's like, okay, this is something that you can do out there during your time, telling her that she, yes, developmentally appropriate, and what she should expect for the next skill to happen.
I think one of the big things to just kind of point out as it relates to that is, did you see how much mom was smiling? Like, you don't get that level of interaction. It's like, hey, fill out this piece of paper and check it, okay, everything's fine. Like, mom was smiling when she was learning about the things that her child was doing, and that can be so powerful. And, most of us in parenting, right, we're trying to promote our parents engaging in positive activities with their kids or learning how to relate to the kids. And in this process, this mom is learning so much about what her child is going to do that should change how mom elects to interact with this child in the future. So it can be, something that's just kind of a simple paper and pencil measure. If you have that opportunity to engage in that process, and maybe in group parenting that's not always feasible. But if you have that opportunity where you feel like there's a real mismatch between parents' expectations of what the child should be doing versus where the child's at, maybe going through that process can really help them kind of connect these two things and reconcile some of those differences. And it may actually help with their engagement within your parenting program. All right, so we're going to talk through kind of how you go about scoring stuff. I will turn it back over to you.
Well, this is Andrew, but we're just going to, now we're going to learn how to calculate the correct age. Okay, so just a little quiz to when do you correct the age? All right, so child's name is Andrew. The date of completion is October 14th. His birthday is April 30th. We're going to calculate how old he is in months and days. So you would take the date of completion. So if you're doing it 14th or you're doing it today, you would do today's date, child's date of birth. Take the year, the month, and the date. You convert into that and you subtract in each area. So Andrew's age at the time of the visit is a year, 5 months, and 14 days, which if you convert it into months and days would be 17 months and 14 days. Now with the calculation, is everybody clear on how this is calculated?
So now that we've made you do the actual math, we want you to know that this is something that you can program into your phone, where essentially there's a free ASU resource. We just plug in the birthday, date of administration, and it will calculate it for you. It takes some of the air out of it unless you input it incorrectly. So for those of you that are home visitors, again, if you have smartphones out with you, having that website, saved as one of your favorites or bookmarked will help you in that process. It will,
And if all else fails, we'll learn how to do it manually.
Yes.
Okay, so 17 months and 14 days. So according to the range here, is this the correct ASU that we use? No. No. Okay. So the next part. Yes.
Yes.
How did you do 17?
Oops, sorry.
We got 17 months because we, the 1 year and 5 months, so 1 year, 12 months.
12 months.
So the 12 and the 5 months. Mm-hmm. And yes, please, stop me if you have any questions or concerns. So, we're going to adjust the age because Andrew was premature. So Andrew was born 6 weeks earlier. So, we take the 17 months and 14 days that we got from the first calculation, and we subtract 6 weeks. And that gives us 16 months. So are we correct in using this one? And again, that's the calculator that we use in, that you can use in the ASU website. You just plug in the date, and it asks you also if they were born, how many weeks early were they, and you can put that there, and it gives you the exact one that you need to use. Okay, now the popular responses for the ASU is yes, sometimes, and not yes. Super easy. Yes is when, Yes is when.
It's Friday. I mean, people want to be done as soon as possible. I'm trying to be respectful.
Yes is when the child is actually performing the skill. So if mom is asking, well, how do I know which one to take? This is what we can tell them. If they're performing the skill, is yes. If the child is performing the skill on occasion, but not always, they can get credit for that. Not credit, but sometimes. If they're not performing the skill at all, not yet, then not yet would be there. Okay?
Am I allowed to get the next slide? Are you sure? Okay. Now I'm not allowed to get the next slide.
Okay, so now we're going to do an activity where I would like for you to think of a child, or if you want to complete this for your own child, to do the communication part of the ASQ and answer those questions, or think of a child in your program, okay? That you may have concerns with. Okay. The communication part, and then we'll start together. Any age, yeah.
Or if you know of a child that you knew them when they were 16 months, so if it's your own child, thinking, not even though it's probably a blur, I can't think that. Give you about 35 more seconds because I don't want to make you think that hard on it. Yeah, just the communication domain.
We went from yesterday. It's really long.
All right, does anybody have any missing items in their own domain? Anybody actually miss anything?
All right, so let's go through it together. For each yes response, you would give yourself 10 points, or give the child 10 points. For each sometimes response, that equals to 5 points, and for each not yet response is 0 points. So just go through them in the line across. You can put the total number of points for that skill, and then add it in the box. And in a real-life situation where you would actually do this for each domain, and then when you're done, you go to the back where the score sheet's at, where we saw that nice looking graph, and you would plot your score on the graph. Okay. And then this is a great resource because you can actually show the parent where their child's score lies. So anything in the white area here indicates that they are developing within normal limits. Anything in the gray shaded area means that you can, that they're not there yet, but you can give them some activities that they can probably, do within their, basic, daily routine at home, and it can stimulate that development, that skill. And in the black shaded area means that it doesn't mean that there's a developmental delay, but it means that they find benefit from further evaluation. So what this area is where you would make a plan with the parent, okay, let's refer you to have an evaluation. So if it's 0 to 3, where do you guys usually refer to? Early steps, okay. So early steps, Fiddlers, if it's over 3. Yeah, perfect. Okay. Any questions on the scoring, on transferring the score? Okay. Now, for some reason, let's say you give the questionnaire to the parent. You mail it to them, they mail it back, they drop it off. For some reason, the parent is not there in front of you. And they miss a question. It's okay. It doesn't mean that you can't score it or in any way it gives them a delay. What you do then is calculate it a different way. Hopefully, best case scenario is make sure they complete every single item. But just in case they're missing any items, what you would do then is, for instance, if they missed one item in the communication, and their total score was 45, but they missed one. So what you would do is you would divide the number of items that they completed by their total score, and that would give you the number of points. Then what you do is add the points that it's giving you to the total score, and that would give you the brand new total score. So 54 points would be their actual score instead of 45. Okay? Which 45 and 54, in some of the cases, it would still remain within a certain area, but sometimes they may, jump a family into a shaded area where they might need referral, and it really is not necessary because they forgot to fill it out, or for some reason I've come across parents who they've never exposed their child to that because of either cultural reasons or religious reasons. For instance, there's a question in the questionnaire that says, has your child offered their image in the mirror a toy? Well, some parents don't allow their children to look at their image in the mirror, so they skip that question because that's something they don't want to be a part of. So, understandable, we respect them for that, and just recalculate it a different way.
And again, we will give you this PowerPoint, so if for some reason you do not have this resource already, this will help you with calculating on the adjusted age, but it also will help you with automatically calculating the adjusted score if indicated. Okay? So again, our goal is we will send Gretel on Monday all of the resources and the PDF, and then we should get all of these tools. If it's open source, for some reason you don't have an open source item, we'll be sending that to you, and that should be disseminated to you hopefully early next week. So if you don't want to write down a hyperlink, you don't have to do that right now, okay?
It also, besides calculating the corrected age, it also calculates for if it's an omitted question. So for some reason, like okay, they only answered 5 out of that, and it'll give you the corrected score. That is your
You already did this? Okay. All right. So, Nancy already started talking about this. I think that sometimes we get parents that even when their child's in the monitoring zone or when their child's in the referral zone, that we really don't get that sense of urgency by the parents of like, well, I was a late bloomer, or his brother was a late bloomer, or we got a lot of things going on right now. Can we just take a wait and see? Or the pediatrician told us we'll go grow out of it. Just so that you kind of get an understanding of, so the section of ASQ when they test this, and again, when they test these things and they norm them, there's well over 10,000 kids that they looked at to kind of see, what's within the limit and what is becoming kind of an area of concern in terms of the screening process. So from here over, so really about 75% of the people that are screened are landing in kind of those white areas on that summary sheet, okay? And then another 13.5%, they're kind of landing in that monitoring zone, okay? So again, they're really at the 15th percentile down to 2.5 percentile, okay? So again, it's something that is a concern. That's why they call the monitoring zone. You want to keep an eye on it. That's why we're prescribing activities for those families if their child is scoring in there. That's why if there's any other reported concerns related, that might be related to the monitoring zone, or if you know some additional information that may place that child at risk for some type of delay, even if they don't end up in the referral zone, it might be worth actually making the referral at this point in time. And then, the below the clinical cutoff, so this is like 2.5, like that percentile and lower. So again, they're doing, at least from a screening perspective or based on what the parents reporting, doing significantly worse than most of the kids, and it really warrants further investigation and further assessment. So it's really important, and I think that's really helpful for us to see, because I think that sometimes we're like, well, if the parent doesn't want to do it, maybe I can just let them do like a refuse, we'll let them refuse, we'll readdress it later on, or we'll readdress it at the end of the parenting group or whatever. But it really lets you that they're not going down a good road if they're at that point. And there is a possibility that some people will develop out of those zones, but when there's a safety net, especially for 0 to 5 for these evaluations, then we know that I mean, how many of you have referred families to early steps? How many of your families got in early steps like the next day? Now, I think by state statute, they have to get in within 45 days, but there's even some wiggle room on that. So you're talking, it may be, a month and a half to 2 months before they even get in. Do you want to wait another month to 2 months? Because if you choose to screen them at the end of the program, maybe it's 3 months, you're really talking about a 5-month difference. And if they could have been getting help for 3 of those 5 months, what kind of service are we providing for their child? Are we helping them reach their potential? So I think that's really important to consider and think about. All right, and that's just going to show that for that. I'm going to go around it in a different way. All right, so depending on your program, are any of you responsible for home visiting? Do you screen just once, or do you have to screen multiple times? Multiple times. Okay, so we have developmental surveillance. For group parenting, I'm assuming that it's screen once and then additionally it's indicated, like clinically indicated but not contractually obligated, I would guess. Yes? So like, for example, if you screen and someone's fine, but then the parent reports, like, we've noticed a stark change in my child's behavior, like clinically it might make sense to make the screening. So from a developmental surveillance standpoint, and each of you are on a different schedule, if you have to do it over and over again of when those need to take place. For healthy steps, it's 6 months. It's home visit. Is it at least about every 6 months you have to do it, or is it once a year? Or depends on the program. Okay, all right. Anyways, I think that even if they score, and Nancy alluded to this, if they score above that, they're in the white area, we want to reinforce, like, you're clearly doing something right. Your child's doing really well. Here's some ways that you can continue in this trajectory. And I think that's really important to do versus, they spend all this time filling it out and you're like, oh, your kid's good. Like, that's very different, if you really want to point out all the things the parents doing well, being very strength-based, giving them ideas of how they can get their kids to the next level. If they're in that monitoring zone, so that's that gray area on the information summary sheet, you're definitely wanting to provide those follow-up activities. I'm going to give you an example of that in a second. Nancy has that as well. And that's one that probably makes more sense for you to engage in some rescreening activities. Even if it's not contractually obligated, you want to make sure that even if it's not at a point of making a referral, that you're checking in to see that either things are moving in the right direction or to make sure that it hasn't dropped into the referral zone. And again, some of those, if the parent's concerned or you're concerned, it's okay to refer if they're just in the monitoring zone. That's totally fine to do.
And these are activities that actually come with your ASQ kit. They have activities for every questionnaire they have. They have activities for every questionnaire. And these are great because it's something that they can do in their daily routine. So during bath time, during feeding time, during, playtime, they can actually do this. So it doesn't take any extra time, and it doesn't bombard the parent with all this homework to do, but this is something that, helps them grow with their child during their daily routine.
Again, I've already kind of emphasized this. I think it's really important that if they're in that referral zone, that we're really doing everything that we can to help refer or link these families to get additional assessment, because we feel like it's in the best interest of the child, it's in the best interest of the parents, it's in the best interest of the family. Worst case scenario, they lose, some time out of their day, but they get peace of mind about kind of where their child is at developmentally. We like to talk a lot about the difference between referring families versus linking families. Does anybody have any sense of what that difference might be if you refer somebody versus you link them? Love it! Come up here and give this talk. I'm going to sit down and relax. Right? So referring, I think, is how many when you give your parents referral, hey, here's a provider, here's a number, call them. How many of your families follow up with that referral 100% of the time? Raise your hand when I get to you, okay? 75% of the time. 50% of the time? 25% of the time? Okay, so 10% of the time? So what do you have to do when they don't follow up with that referral? Okay, so you got to go over that whole process all over again, right? And that takes time. And then when you give that referral to them the second time, how many are at 50% on that second time? Anybody get to 75% on that second time? Okay. So how much additional time, and then it's a cycle, there's a third time, and then that time that's going by the child's not getting that additional assessment. So taking that extra time to link the family. So early steps, they have a passport where you can fill out the form, you can attach the ASQ, you can fax it, you can follow up with the family within a certain number of days, making sure that they actually received contact from early steps. You can have the family sign a release of information so that you can call early steps and advocate. This is for any place you actually refer to or link to. How many of your families have smartphones of some sort or cell phones? All of them, right? Pretty much. Yes. Okay. How many of your families, if they receive a phone call from someone they don't know, actually answer the phone? Not very much. So here's step 2 in this linking process, okay? You're going to have them program the number of the agency. And again, it doesn't always work perfectly because they might be calling back from, they're going to put in the number of the agency to the phone as a contact, okay? If possible, you're going to have them call or you call with them to that agency, whatever that referral is, if it is a place that you're calling for, so that you know that that actually happened, right? You made sure. So you were talking about handing off and making sure that connection is actually made. It decreases your need to follow up because you were right there with it. Like, you know that it actually happened, and it was immediate. How many of you, like, when someone says, hey, you need to go get this checked out, how many of you, like, get busy and kind of forget about it, and then, like, 2 weeks later, oh, yeah, I got to do that, but, like, I don't know when I'm going to fit that into my schedule. Like, we all experience those types of things. So I think it's important for, if you identify a concern, it's immediate, right? We're linking you immediately. We're demonstrating that it's of importance versus, hey, go get that checked out, and then you don't talk about it for like a month with the family. So I think that that's really important for you. I don't know if you want to add anything to the link.
I think it also it develops that relationship between you and the family because they see how much you care and how concerned you are. And if you take, I mean, I have the ability to do it right then. You know, that same family, let's say that there was a concern right then and there. I'll call, you know, and it's great to, and they have friends in other agencies. Hey, I have a parent here, pass the phone to her. And that's one less thing the parent has to worry about, one less thing you have to worry about. And it, you know, you just follow, making sure that they actually also sign a release information so you're able to get reports back because if for some reason they forget, maybe you can work on the side of the provider. Hey, you know, really need you to contact this family if you can please, and that gives you permission to talk to them about it too. So it's great at different levels for both for them and for us.
And I think that, you know, let your families know that you're willing to go to bat for them, and when you're willing to go to bat for them with what you perceive as being in their best interest, I think it increases the likelihood that they're going to engage in what it is that you're trying to teach them or educate them about within your specific program that you're providing. I guess I never really explained the wastebasket thing, but it's like you hand somebody a piece of paper, like how many people have a piece of paper, or like you get a business card and like you still have a business card like 2 months later, like, I don't know who this is. Like, I don't know who this was, right? All right. So in terms of, and if people have other ideas of places you're going, but as it relates to kind of ASQ, birth to 36 months, we're referring to early steps north or early steps south. Nicholas's Children's Hospital now. It's the Golfing Hospital, not so much Miami Children's Hospital. So if they live north of Flagler, they get referred north. If they're south of Flagler, they go south. Again, we're going to provide you with all of this information. That's through up until the day they turn 36 months. So if you have somebody that's getting close to 36 months, it's really important like you make that linkage right away so that they're actually getting in that process. Fiddlers is 36 months to 60 months. For your group parent training, group parenting programs, if you have a group, who wants to go in all in of like, hey, we have the largest parent groups, like we have a cohort of this many at a time. Who here's got the biggest group? I don't do group parenting, so like in our little group parenting we do is like.
How many parents in a group?
Yeah. 12. Okay. All right. 17. All right, 17 is the lead. Do I hear 20? No. 21. Oh, okay. So, do you have time to do all the case management for 21 parents if like 15 of those kids like score in the referral zone? I like stress you out a lot just by saying that, right? So I don't know if you had, it depends on what your team consists of, but I think Help Me Grow, so like they also do developmental screening, but they are also a linking agency and they're helping with 0 to 8. So that's another resource that you can utilize in terms of helping with that. Or calling the switchboard if you're not really sure, they'll help direct you. We're all aware of the switchboard now because we're contractually obligated to have our programs on the switchboard of Miami. And then on the ASQ, on that summary sheet, it kind of has that action sheet of kind of what it is that you're going to do next and kind of what goes into, that note and kind of what are the next steps and when you need to maybe rescreen or something along those lines.
And just to go back, to piggyback on what Jason said with Help Me Grow, they're a fantastic program. You can call and connect with parents. You have referrals that you can tackle with them. You can have them call directly. And what they do is if your program links with them, what they can do is at the end of the week or the end of the month, they can send you a report on the parents that they've actually contacted and what has happened after that. So they're really good at that. And I saw a bunch of nice brochures over there in the lobby of Help Me Grow. So those are.
So let's wipe them out before we leave at the end of the day. So this probably should actually go when you're introducing. It should actually move up in the slideshow, but it's about talking to families when you're explaining it, just letting them know that it's a tool to check on the child's development, letting them know, like up front, like, hey, your child's going to be able to do some of the things. It's quite possible that they won't be able to do all of the items because, like, worse, like the second that they're like, oh, it's just marked not yet. What's wrong with my baby? What's wrong with my child, right? Like we have those anxious parents that it's their child is not doing all of these things, and all of a sudden they're very concerned. And depending on how you administer it, so maybe you're a site that's going to mail it and then return it. I don't advise that as the best opportunity of doing it, but let's say that that's how you did it. If you have an anxious parent that like mails it in, and it's like maybe a week or two before you get to review it, and like they're like worried or freaking out about whether or not their child's actually okay. And just letting them know that the answers help show their child's strength in any areas where they may need support either from the parents, to provide additional detail to that, or more practice in the area. Before reviewing the results, I always ask them, like, hey, do you have any concerns about your child's development, their behavior in general, or do you feel like they have any difficulties with learning? Again, that's in there as well, but I feel like that's something that if you get that parent concern, for a lot of parents, maybe they have seen some things that are concerning to them. There's going to be some families that it's going to be a complete shock, but I think it softens the blow a little bit. Like, yeah, we've been a little bit worried about, I thought that my child would be walking by now, but they're not walking, and I'm a little bit concerned about that. It allows you to kind of have more of a discussion versus like, and here is the results, right? It feels like a more natural therapeutic conversation you have. Or if they're unconcerned, but the ASQ indicates a problem in a particular area, asking a more leading question. Well, have you ever noticed that your child's not, crawling yet, or things of that sort? I don't know if there's anything you want to add up, like little tips of the trade that you go with when you're going down that road.
Yeah, I usually, and parents sometimes they think that they like to compare to their other children also. It's like my son was walking at this age, and my daughter's not doing this. So making sure that you educate them on like, well, there's not a specific age they should be doing that. There's more of a range. Giving them, some education on that, I think calms them down a lot, especially since, they're going by the book. They're not all sure they go by the book. Another thing is that if a parent, let's say, in the ASQ, they did great. Everything's within normal limits. The parent is still concerned. I would still do a referral just to ease the parent's mind because they have nothing to lose with going to There's always a program or.
Depends on the time or the parent.
We'll get to that later.
We'll get to that, yeah.
All right, and then if it's, again, reaffirming to the family that this is a screening tool, it doesn't diagnose, but it is suggesting that there is some concern that warrants further evaluation, and that there might possibly be a need for your child to need some additional help. We won't know that until we get that additional assessment completed. Obviously showing empathy as a parent's concern, using some reflective listening as it relates to concern. Don't say this is difficult to hear, isn't it, if the parent isn't upset, because you don't want to alarm them if they are not feeling super alarmed. But I think, emphasizing like, hey, just like our parenting program, we're really about, focusing on making your child and you have the best relationship possible and make your family function in the best way possible. And if we really have a good sense of where your child's development is, that's going to actually help us when we're teaching you during the parenting program how you could actually interact maybe a little bit differently with your child to get the most gains or to get a better understanding of kind of what you could expect so you can adjust your reactions to when you're interacting with your child. All right, 1 out of 5 done. Let's do this. We're rolling. Any questions on ASQ 3 before we move on to the ASQ SE? So, to be clear, there's an ASQ SE and there's an ASQ SE2.
And that's the reason you don't have copies of that, because there's a new form that.
There's a new form that just came out. The Children's Trust is allowing programs. I think that they probably want the newer programs if possible to be doing the ASQ SE2. From looking at it, I actually think it's probably more user-friendly than the first ASQ SE. We personally have not switched it, but so who all has to do ASQ SE training as part of the contract? Okay. And how many people have already made the switch to ASQ SE2? Anybody? Nobody. Okay. So we'll go over the ASQ SE in detail. We'll give you kind of a quick overview of kind of what are the differences between ASQ SE and then the second edition, just so that you know that that is the case. My understanding is this is kind of a transition year, but the expectation is that everyone should be using the ASQ SE2 by the start of next August. So if you find that your staff is having some difficulties with the ASQ SE, you may want to make that switch sooner than later. Okay. So we'll talk about what is actually screening and kind of going through the administration scoring process. This is always a little bit of an interesting thing because if your child scores positive on an ASQ SE, many of you, one of the reasons why you're working with the family is because maybe there is some concern about the child's social and emotional development or risks for social and emotional development problems. So like sometimes it's not a referral to another agency, it's just you knowing like, okay, yeah, this means that this is a good fit. You're in the right place. We're here to help you with these issues. Right?
So ASQ SE, this is a little bit different from the actual agency stages one that we just went over. Instead of starting at it will start at 2 months, the new SE2. This one that we're currently using starts at 6 months of age all the way up to 5 years of age. They're spread out a little bit more than the ASQ. ASQ saw that they had about 6 months to 6 months interval. This one has 6 months. 4th to 5th grade level, reading level also for this, and they have anywhere from 19 to 33 for questionnaire.
It kind of has a wide range of kind of problem behaviors, even feeding behaviors, which it may not. I mean, how many of you specifically address feeding behaviors as a part of your intervention? Right, so like interesting things like that may pop up, and we know that there's like feeding issues or coercive parent-child interactions related to mealtime, and that can actually be related to other problems. In terms of the measures and kind of what they're trying to gauge, obviously within that first 12 months, we're looking at the child's attachment. You'll see regulation really show up across all of the age ranges for the ASQ-SE. Regulation, so a child's ability to kind of independently, as developmentally appropriate, regulation an emotional state, or if a child is in an upsetting situation, they're able to calm themselves down. The reason why you see this, so you see it happens in 0 to 12, you see it show up as self-control later on. It's something that's really important in terms of child development because kids that have emotional dysregulation are at increased risk for depression, anxiety, oppositional defiant disorder, conduct disorder, just lots of not so great things. So that's kind of that common thread of why a child's regulation is so important. And oftentimes, where do you think children learn how to regulate from? Parents. If you have a child that is dysregulated, many times you have parents who are also dysregulated. So it can be a nice parallel process. I will say that the ASQ-SE, because it only gives you one score and doesn't give you domains, that is definitely, especially for parenting, that is a tool that is much more relevant for you to go back and look at the specific items that they're endorsing because it will allow you to tailor your parenting program to that parent's and family's specific needs. Obviously, a child engaging in more independent behaviors, being able to differentiate their self versus others, moving towards make-believe or pretend play, beginning to follow simple rules. In terms of that social development, are they beginning to develop peer interactions? Is it parallel play that then becomes interactive play to meaningful conversations with peers, and things of that sort? I've kind of gone into some of that stuff here. In terms of like their ability to be adaptive. So you have kids that are very rigid, very fixed, and if anything in their schedule goes off, it's very difficult versus kids that are far more flexible and they can kind of roll with changes and regulate in those situations. Their ability to demonstrate appropriate feelings, understand feelings is also something that is of importance that kind of the ASQ-SE is trying to get at.
Okay. So with the ASQ-SE, it's completely parent completed. Unless you see that there may be a literacy problem or anything, you can do it by interview, but it's usually completed by the parent. There's no cute little kids that go with it. They're available in English and Spanish, containing to the ASQ, and each interval has separate summary page, and they each have their own cutoff score. Okay, so it's not like same scores that work for the ASQ. So these are the scores for the SE. So the answers, you know how the ASQ was yes, sometimes not yes. For the SE, it's most of the time, sometimes, never, or hardly ever, and if there's a concern. Most of the time, depending on the question, it can be either 0 or 10 points. Sometimes it's 5, never, hardly ever, 0 to 10, and if there's a concern, they get an additional 5 points.
There's a super secret code for how you're actually able to figure out which way, if it's a 0 or a 10. Sorry. And the higher the score, so unlike the ASQ, where lower scores are indicative of either monitoring zones or referral zones, the ASQ-SE is different, so higher scores are indicative of problems.
Okay. And at the end, so those are the questions that parents answer. And then at the end, there's open-ended questions where, for example, do you have concerns about your baby's eating or sleeping habits? So they have an area where they can write their concerns, write their comments. Is there, what things do you enjoy most about your baby, for them to share that with you. And they also, if it becomes a concern, they also get 5 points added to that.
So this is just kind of showing that looking at all the children in the norming sample again, we see those lower scores that reflect most of the children, and the higher the scores, fewer children are just below that, suggesting again that there's an increasing concerns in terms of that child's social emotional development.
Okay, so again, administrator can mail it out, you can do it on Zoom, an interview, it can be done anywhere actually, pediatrics, child care.
Well, I mean,
oh, okay.
All
right, so administering it. So, each questionnaire has different sections where we talked about most of the time, sometimes, rarely, or never. The thing you have to indicate to the parent to be very careful, and I'm sorry, I don't have these for you because since we're giving the other one, I don't want to focus so much on this because the new one is going to be different. Each area has, it's different from the ASQ because the ASQ is everything in it is consistent. Yes, sometimes not yes. Yes, sometimes not yes. This, they have to actually pay attention to the Roman numerals. So it's indicated V for 0, the letter V for 5 points, and the X is for 10 points. Okay, so they have to be very careful to the answers that they
use. Code. You are now cracking code.
Very friendly.
Yes. So they actually, this is for our scoring purposes. As far as them, they just have to make sure that they answer correctly. You know, most of the time, sometimes rarely or never. The new one I hear is going to be easier, so hopefully it will be. So what you do is just tally up all the questions with the X, with the B's, 10 points, 5 points, and any concerns are usually on the side or at the end that parents have. You give them an additional 5 points. You total each page, and at the end it has, the score sheet with each of the cutoffs. So each interval has its own cutoff.
And we were ahead with the cutoffs moving in a different direction. In the ASQ-SE, which is probably what most of you have right now, there is not a monitoring zone. In the new ASQ-SE, the second edition, there actually is, which I think is helpful and it gives it much more like a parallel process. It feels like a true companion to ASQ-3. I think that one of the things you have to consider is how many of you, how many of you have screened with the ASQ-ST prior to this year? Yeah. And in your program, if they score high in the ASQ-ST, does that make them appropriate for your program, or does that typically make them, do you typically have to refer them someplace else? Okay. So, it depends on the program. I think, again, that 0 to 5 age range, you saw that taking that. You can do referrals to early steps, fiddlers. I think that, sometimes you'll see an overlap between their ASQ-3 scores and their ASQ-SE. Right? So we know that developmental behavior and social emotional development go hand in hand. Sometimes there's cultural factors in terms of what is expected of a child's behavior. There's a acculturation issue in terms of what was perceived as being normal in the parent's country of origin versus what is perceived as normal here. So just making sure that you take, or if the child has been, sick for a span of 3 weeks, is it something that's more situational, or is it something that's more chronic for you to kind of take into consideration and choosing to make that referral? I think that there's always a concern of the validity of reports. So I feel like, does anybody serve parents that either have a criminal history, or juvenile history, or parents that are involved with the dependency system? Okay. So a lot of times you see with those parents, especially if it's asking about child behaviors, because I think it may reflect back on them and their parenting, they may take good on these things. So you have to take that into consideration in terms of what you do with that information versus just assuming that it's completely and totally valid. Obviously, things to consider, is the parent's own ability to be coherent in their own decision-making, perspective-taking. So obviously, if they're engaged in any type of substance abuse, to the extent that a parent is depressed or has other mental health concerns that may impact how they view their child. And, I'm sure that, many times when you hear someone say that this is a problem with your child, that after talking with the family, you realize that it's really the parent with the problem versus the child. So just keeping all of those things in mind when you're considering that. Similar to the ASQ 3, if they're below the cutoff, there's also activities that you can provide. If they're close to the cutoff, follow up on those concerns. You may want to make referrals as appropriate. The ASQ SE2 is very clear because there is a monitoring zone, so it's kind of differentiated from the old one. Possible follow-up, you could be referring to early steps or fiddlers. If you look at the items and it seems like it's really related to feeding issues, I don't know that we have tons of feeding clinics around here, but something to consider. It could be community mental health providers, parenting groups, so you're referring them to yourself, or maybe you're a program that has different levels of parenting or different levels of intensity of services. And maybe you're at the universal prevention level, and maybe that they just need to go to the next level of service. I mean, those are all agency level decisions that you need to consider. Maybe referring them back to the primary care provider for further evaluation. So obviously kind of considering each family's in place, kind of what is, and I talked about this some, making sure that we really don't make any assumptions about concerns, priorities, or resources for families. Specific things paying attention, so like, we think about, we're taught developmentally that if a child avoids eye contact, that may be a symptom of an autism spectrum disorder. However, within a specific culture, it may be deemed disrespectful if a child is giving someone eye contact. So really just kind of taking those things into consideration, whereas, some cultures where it's perfectly okay for the children to show tons of loving affect, hugging, whereas in other cultures that may be perceived as something that is frowned upon, as something that is not how things are done. So take that into consideration as well when you're administering the ASQ-SE. So obviously, we know that ASQ-SE, identifying folks are really important. We talked about that linking process. We think that, the more that you can have a team approach, I don't know if you, as a part of your group, have the ability to kind of staff things and bounce ideas about the families that you serve off of one another. I feel like that's really another resource. Help Me Grow can also be helping you with linking these families to services if you don't feel like you have the capacity, and that's something that is free, and then they can also link them to services that are low cost on, a sliding fee scale that are available through the Switchboard of Miami. All right, 2 out of 5. We're getting there. Getting closer to the end of Friday. All right, so this is our good friend Jane Squires, who I've never met, so she's not really my good friend, but she's going to tell you about the ASQ-SE2, some of the new features. We'll go through that quickly, and then probably what we'll do after we get through the ASQ-SE2 is we'll take like a 5-minute break, and then we'll hammer through the last 2. Okay? All right.
Social emotional development is important for young children because it's really a key to success in school, in social environments, in environments at home and away from home. It's really kind of the best predictor that we have of academic success also. Early identification really is the key to optimal development. So if we want children to develop at their utmost capacity, we need to find problems early. The Ages and Stages Social Emotional is a series of 9 questionnaires now that parents would complete at about 6 month intervals. It's a series of questions. It varies by the age of the child. And the questions are all targeted at child's developmental level. The parent has 3 options, whether the child can always do the behavior, sometimes, or rarely or never. And some behaviors are positive, that you want the child to be doing.
Secret coding system.
Having meal times be happy, playing with other friends. Or there might be negative behaviors, such as having difficulty with transition or having tantrums that last, a long time. By looking at these social emotional skills, by really keying in to how the child is interacting with their environment, then we can catch delays or problems or even challenges for families early on and do something about it.
Book publishing is really committed to developing content that helps people meet their full potential. And obviously, a product like ASQ meets that training, that mission. The reason that parents parents really like ASQ is because it's not scary. It asks normal things about what children do, and it asks them in a warm, positive way. We're really excited about the changes in ASQSE too. We looked at a new sample, so we collected about 16,000 questionnaires, looking across the ages from 1 month all the way up now the upper age range is now 72 months. So we can look all the way up to 6 years, and we've updated the cutoff scores and the new monitoring zone so that hopefully these will be very accurate and effective as a screening system. Our goal is to make something that you don't have to be a professional to administer. We really want to make it user-friendly. I would say it's exciting to be able to revise it. It's exciting to have our colleagues at Brooks who are willing to kind of work with us and improve the layout and improve how families can use it. I don't think there's anyone who works at Brooks Publishing who doesn't feel great that we're the publisher of ASQ. To really feel like you're working on something that will change people's lives is amazing. I'm so grateful that I've had the opportunity to work on this project that really has helped people around the world. It's truly an honor to be involved in this.
Can anybody tell which website I might have gotten this from by any small chance? Brooks Publishing, baby. So that's a nice summary of the changes. So the biggest difference is that there's now a 2-month protocol, which is great because it allows us for even earlier identification if there's concerns. The other thing that I like that's a change that kind of mirrors kind of a lot of how we think about children's behaviors and kind of the focus of children's externalized behaviors. So their disruptive behaviors, that they argue, regulation issues, internalizing behaviors as a list of kind of anxious or depressive type symptoms. So I'm glad that they're kind of taking a look at those things as well as the things that they were looking at within the ASQ SE2. You saw that Samantha's has been the ASQ SE, that they have to pay close attention of kind of sometimes the question type changes a little bit. They have it so now it's, often or always, sometimes really or never, so it keeps it consistent. So I would imagine that the number of missing items now is going to go down with this new administration. And the fact that they actually have that monitoring zone, I think, is a really nice feature. So you see that they have the 3 sections. I don't think it was a summary sheet. And then there's, now there's that monitoring zone, which I think is a nice, cleaner thing to actually provide for the family. So again, I think for my program, we haven't switched yet, but I think we're going to go ahead and make the switch just because I think it's more clinically relevant and useful, and it aligns more with what the ASQ3 is. And generally speaking, it seems like programs have more money for program supplies year 1, so just suggesting that maybe that, I don't know, just throwing it up there. Scored in a similar way, and that's what you said that went over it. It's not all that different, but we just wanted to kind of point out some of those key differences. All right, 3 out of 5. Woo! Getting close to the end of Friday. Let's take a 7-minute American time break. 7 minutes at 3. What time is it actually? Sorry. At 3:20. Okay, so at 3:20, we will restart whether or not you are in this room or not. So 3:20, we are restarting. American time. What are you doing? Are you excited?
Yes. I think they kind of bring it by
So what we need to do is,
I scan it, but we need to originally.
right. We recalibrate them.
Can you it to me? Forget it, and I'll drop it off on Monday.
No, I'm happy.
Oh, so you go in there? Because it's not a close. Nice.
You're gonna drop that.
I need that contact. Okay, I'll take it.
I'm gonna white out my signature.
No, but my question is, I just need directions. I know where it's in our restroom. Oh, thank you.
No, it's right off the dress board.
And probably going around every time.
There's so many stats. We're in pediatrician's offices, so we take home from the lunch health business. We get parents and experts and they do homework. And then parents try to interact with them. The other do is like a live play. There's a bug in the ear. Parents try to interact. But it's so. And there's like a white power and there's a yeah.
And he's going to get her. Okay. Let me call him.
Okay. Bam. All right, we're going to go ahead and get started again because, you know, I don't want people giving me dirty looks when we get close to 5 p.m. How many folks have actually administered the MChat before, started administering it this year? Got any MChat? No MChat takers in here. Okay. So we have moved on. No, we're moved on to the MChat. Which, did everyone get it in chat? Yeah, all right, so you have that. So the MChat was really developed for a toddler population, really aiming at 16 to 30 months, with the goal being to screen for kiddos that may be at risk for a diagnosis of autism or a related disorder. Just so that we all kind of get in the same space or have some talking points of kind of what autism is, because, like, if you tell a parent, like, hey, I'm going to be screening your child for autism, it's like, okay, but, like, what does that actually mean? Like, you at least want to have some foundation of being able to explain what autism is to the family, kind of what some of the features are. You know, again, as part of that informed consent. They want to make sure that they know what you're actually screening for. All right? Remember, oh, people have taken to the cookies. All right. Go ahead and steal some more if you want. So when the DSM-5 came out, they no longer separated the different type of autism diagnoses. The diagnosis now is just kind of one unified word that kind of exists on a continuum of severity. There can be associated features such as ASD with or without an intellectual disability. Some of the key features include persistent impairment in terms of communication and interaction. So maybe the child has back and forth difficulties with conversations, parents trying to talk to the child's essentially non-responsive. Or the child only wants to talk about things that are of interest to that child, and it's usually sometimes peculiar interest. It's characterized by poor eye contact and difficulties establishing and maintaining relationships. It could also, a feature of autism could include repetitive behaviors and at least 2 of the following. So repetitive speech. So this can also be tricky in terms of trying to assess a child's receptive language or their expressive language is the parent will talk, yeah, well, whenever, you know, I say something to my child, they just say it right back to me. It's almost like they're parenting in the process. Lining up toys in a very particular way. It can be hand slapping when they're getting excited about things. Kind of that having some difficulties with flexibility in terms of routines and things like that. Fixated interest, so it could be maybe like really hyper-focused on Thomas and Train, and everything has to be Thomas and Train, nothing else. And then it could also include a hyper or hyposensitivity to sensory inputs. So that could be auditory in nature, that could be visual, that could be tactile in nature. It's something that should be present on some level at an early developmental period, and like any other diagnosis, it needs to cause impairment, functional impairment in some way. And that these features that we talked about, these key features, are not better explained by an intellectual disability. All right, so who's ready to go and diagnose some autism? You're ready? All right. I'm going to go home, and you can take it from here. I like it. This is awesome. All right. So within our role, at least with using the MChat, our role is to screen, not to diagnose. Slacker. I mean, look, everyone else is back. You know, if the screening positive doesn't mean that the child has autism. What's what's nice is for those of you that are doing developmental surveillance and that you've been seeing the kids before, is by the time that you're getting to the point of administration of the autism of a young child, usually if you've been given the ASQ3, even though the ASQ3 does not specifically assess, for autism, there's some things that you've noticed along the way that kind of maybe tip your hat when you get to the MCHAT. And if you've been talking to a parent about development and things of that sort, then maybe it's not as big of a surprise versus somebody that has not gotten into developmental surveillance over a period of time. Obviously, like the other things, if they screen positive, there's clearly a need for further assessment. And to the extent possible, because we know, like anything, so like early intervention for developmental delays increases the likelihood that children catch up. Children who actually have autism spectrum disorders, if they get evidence-based interventions early on. I like wandering, I don't know. If they get evidence-based interventions early on, it increases the likelihood that they will show greater improvements over time versus if those start at a later time. So, why do we screen? Well, some would say that there's an increasing prevalence of autism. There's a variety of reasons that people suggest. Again, I'm not, there's no research that actually suggests that vaccines are related to autism. I'm not going to go down that road today. I think one of the things is that we didn't understand what it was very well. We didn't define it very well maybe 20 years ago, 25 years ago. So I'm not sure that it's necessarily an increasing prevalence. Maybe it was there before, it was just diagnosed as something else, or it went undiagnosed. So I think that we're doing a better job of actually knowing what it is and assessing for it and screening for it. ASD can be reliably identified before age 3, but on average, kids are not being diagnosed until after the age of 4. And for kids that come from low SES environments, so they have a low socioeconomic status, or if they're from a minority population, that diagnosis happens even later. So who's our population that we just talked about? It's like this, in the parentheses, that is a big part of the population that we serve. And part of this is about trying to reduce, a disparity and making sure that these kids, are getting identified earlier and getting services earlier so they have an opportunity to catch up like everyone else does. Generally speaking, within pediatricians' offices, this would happen at 18 and 24 months. So it's happening at 2 intervals, depending on your program and the duration of it, you may only be screening once. So it's a screening tool that's looking for early detection. We're trying to get, children identified very early on. We do this above and beyond the ASQ3 because ASQ3 is not designed to screen for autism. The communication of social delay may be confused with shyness and behavior. So we want to make sure that we're differentiating between shyness versus like an actual feature of autism. The goal of the MCHAT really is to try and capture as many cases as possible. And because of that, initially when they developed it, there was a really high false positive rate, which, as you might imagine, if you have a really high false positive rate, that means that kids are screening positive on the MCHAT, but they don't actually really have autism. That could be raising a lot of concerns and anxiety for parents. So then they included a follow-up interview to help reduce that. And then they renormed it a couple of years ago to even work even harder to kind of get that down so that we're not raising as many red flags. So this is, MCHAT in terms of picking things up, it's pretty solid in terms of, capturing the population. So if the prevalence rate of autism is over 1%, it's 93% of folks that we screen are just with the MCHAT, not without the follow-up interview. Only 7% of folks are failing it. Okay, so we're getting within 6 percentage points. So it's actually pretty decent. And then of that 7%, more than half of them who complete that no longer screen positive. So we're getting down to about a population of 3.5%. So that 3.5% to to 1%, you see that it's pretty well defined. Like, we're not over-referring when we get to that point. And the mean evaluation is happening around the age of 2, a little bit older than 2. So again, we're screening for this much earlier than that, average age of diagnosis that's a little bit over 4. We're getting 2 years earlier if we're actually using this tool, which I think is really cool. While it's good at picking up autism, it also is going to think of other things. So you're going to have people that are scoring in the referral zone on the ASQ. They may also show up on the MCHAT, okay? So it actually correctly identifies about 98% of toddlers with developmental delays, and then it has about a little over 50% hit rate. So of that 3.5% that get screened for it and still fail the follow-up interview in the MCHAT, half of those end up being diagnosed with autism. So, I mean, that's pretty solid for a screening tool. And that's why I think it's really important for you to really treat this in a very meaningful way when you're doing this with families. So the MCHAT is screening a wide range of behaviors with things that are associated with autism, and kind of looking at whether or not the child has difficulties in those specific areas. It's a 2-step screening tool. It really can be maybe one. It's a 1-step screening tool for about 93% of the people that you serve. 20 questions. It's a little bit higher reading level than the ASQ, so it's at a 6th grade reading level. There's a lot of different mechanisms for how you can actually administer it. There's the ability to administer it online and get a printable PDF report of it, but it won't do the follow-up interview for that. They used for the old MCHAT, maybe they've updated. There used to be a way of administering on a smartphone. Even I don't know if it's been updated to more recently have the MCHAT R. It's available in English and Spanish. There's 2 different Spanish versions, and we'll give you the website for the resource for the MCHAT. It's an open source free measure. You're going to have to look at those versions of Spanish to see which one actually makes the most sense for the population that you serve. They also have a pictorial version, so kind of helping people actually see what it actually looks like so they can better answer the items. The way that it works, so like the ASQ3, it has a total score. The ASQ-SE has a total score. For the MCHAT, if the children fail a specific number of items, so it's just the number of items that they fail, dictate what are the next steps. And it's something that can be scored pretty easily. It's not probably quite as user-friendly to score as the ASQ3 and the ASQ-SE. There's a couple items that are reverse scored, and Nancy is going to talk about that in a second. Depending on your setup, there is a template, so you can actually have a transparency template that you can put over it that makes it easy to score very quickly to assess the number of failed items. There's an Excel template. These are all resources that we will send to you and give to you where you can actually input all of the answers. And then you can actually administer the follow-up interview using the Excel sheet. So for those of you that are out in the field, you can probably transfer that Excel sheet to a Google Sheet and access that on your smartphone and maybe administer it that way. I don't know. I mean, you decide. Just throwing out kind of different options of how it can actually be administered. All right, Nancy.
So these you do have copies of the MCHAT. It also in the front page and in the second page it gives you the website where you can get all the items such as we're talking about the template, the different languages it comes in, newer copies of this, and instructions and the follow-up questions also. So to be scored in less than 2 minutes is based on pass or fail. When parents answer it, it's based on no or yes. Simple, no special code, nothing like that, either no or yes. And the follow-up interview, if needed, is based on pass or fail. Now, For the items, so the items, the questionnaire, have that in front of you. This is the simplest way that I've known before. Questions 2, 5, and 12, if you want to circle them. Those, the answer you're looking for, the appropriate answer would be no. Okay? Everything else, the answers you're looking for is yes. Okay? So if you have an answer other than those, for those certain ones or for the rest of them, then you would give them a point for each question that is the opposite of what you would expect. Okay? We'll go over it again. I'll give you a couple minutes to fill that out yourself so we can all score it together. So go ahead and either, this is usually given as early as 16 months and can be given up to 30 months. Usually it's given twice. So you can start, we usually give it at 18 months and then again in 24 months. So if you have a child that, you know that you're concerned with, you can go ahead and answer as if you were the parent of that child, the guardian. Go ahead and answer the questions and then we'll score it together.
About 45 more seconds. You're ready to be done with product. Okay, finish up the last couple items. You're not quite done. You can just arbitrarily mark something.
Okay. So, again, let's go. Number 2, the answer should be no. If it's not, assign 1 point to that.
That means 1 failed item.
1 failed item, exactly. Number 5 should be no. If not, we're going to assign yourself a point for that. And number 12, you're looking also for no. All the other questions should be a yes response. If it's not, they failed that item. So any no answers for those, assign a point for each of those. No.
And then you're going to sum up the total number of failed items.
Let me know if you need me to explain it again. Yes?
So let's walk through it again.
Okay. So numbers 2, 5, and 12. It gives you a choice, yes or no. The appropriate answer we're looking for is no. So if the parent or yourself, you're pretending as a parent, if you've answered yes to one of those 3 questions, you assign yourself a point, which means
For
that's
each
one
item.
failed item.
So how many people have a yes on 2, 5, or 12? Anybody? Okay. How many do you? 3? All right. So you have 3 failed items so far. What do we got over here? 3? 2. Okay. All right.
Failed items.
Okay.
2 failed items. So, and all have an answer of yes. So if you have anything other than that, that's a failed item. So also calculate that during your test.
So you're counting those. Yes.
I have a question. For example, for number 10, my son is 4. If he is in front of the TV, he doesn't know it. He doesn't respond. He has him right.
Well, remember that this is
So
only.
in that case, I would say yes or no. Maybe sometimes it depends.
Well, remember it's 16 to 30 months, right?
Oh, okay.
So it's for a very specific age range. And the reality is, well, no, it's okay. Even if they answer yes in that, if they are, and we'll go over kind of what happens, if that was the only failed item, okay, that's fine. We're not worried, okay? But if they fail several items, we're going to ask more questions about each of those items because you're like, well, like, I need to explain this, it's not really that they don't know it, it's just they're so focused on the television. So the follow-up interview allows you to clarify some of those things and get a better sense of, is it really what the item was intending to measure, or is it capturing something else? Okay? 16 to 30.
16 to 30. 16 months to 30. So anyone total score is from 0 to 2? 0 to 2 points?
Well, did everyone add up their other failed items? Is everyone good with how to add up the other failed items? So how many people had that 0 to 2? So total number of failed items was between 0 and 2. Raise your hand. So that if you were administering to that parent, no follow-up would be needed at that point, unless there's something else that has been told you that would suggest that there's a need for additional. So you wouldn't go to conducting the follow-up interview.
And if they're less than 2 years of age, you can go ahead and re-screen them, again at the next visit after their second birthday.
How many of you had between 3 and 7 failed items? Okay. So in that instance, and this is an awesome change, that you weren't using MChat before. The old MChat is if they failed, you had to administer all 20 follow-up interview questions, which can take a really long time. If they get between a 3 and 7, is you only have to administer then the follow-up interview questions for the specific items that they failed. Okay? And then
the follow-up interview is 22 pages, because it has you're questioning them again for each of the items. But if they only failed certain items, you would only ask the questions that they failed. Okay? And that's available in the website too. That's why we didn't print out 22 pages for each of you. That'll be awesome.
I think the other piece that's important to consider with this is you probably don't, just like we didn't want to print out a bunch of, sheets, is you probably don't want to put out like 500 copies of 22 sheets either. So something just real simple that you can do if you have to give the follow-up interview is print out the interview once, get it laminated, and then just use a dry erase marker so it's kind of reusable. That's just going to low-cost resource to save you on printing costs. Remember, only about 7% of the people that you screen are going to require the follow-up interview. Now, if you administer the follow-up interview, and again, it's only, so if you failed item 4, 7, and 13, and that's it, when you go to the follow-up interview, you're only asking follow-up interview 4, question number 4, follow-up interview question 7, follow-up interview question 13. Just those 3. That's it. You're not doing 18, 19, 20, just the ones that they fail. And if for some reason after you administer that, and this is where it gets a little bit tricky with the scoring, right? Because if they fail it the first time, if they have between 3 and 7, you do that follow-up interview. But if they are still failing 2 items, so the threshold is a little bit lower, if they're failing 2 or greater items, then you have to make that linkage for additional evaluation. And then I think the other nice feature is if they have 8 or greater, you don't have to do, like, okay, there's something going on that warrants further assessment. You don't have to do the follow-up interview at that point in time. you can bypass the follow-up interview and refer them. Unless you're getting some parental resistance of like, no, I don't think that this is my child, then you may need to go through that to clarify to make sure that that's really what it is.
And the follow-up interview is very simple. What it does is you're basically just asking those questions again, but in a different way. So, for example, you were concerned of number 10 you brought up. So number 10, the example of the follow-up interview is, does the name of the child respond when you call his or her name? That's the name of that's the question. If they have responded yes or no. It tells you, it's really easy, it tells you if they answered yes, what else you should ask them. If they answer no, it tells you, okay, then, they passed that.
So can you actually walk them through like the algorithm for one of them, just so they understand how specific it is to kind of alleviate some of those
So let's say, does, just little Joe respond when you call for his name? If you say no, next question would be, if he is not involved in something fun or interesting, what does he do when you call his name? So the parent gives you an example, okay? Then you go ahead and ask, so it tells you exactly where to go. So do they look up? Do they talk? Do they babble? Do they stop what they're doing? If it tells you yes or no, it indicates, okay, they passed. If it tells you no, then you indicate, okay, ask these questions. So they make no response, seem to hear but ignores parent, respond only if parent is in front of the child's face, respond only if touched. Okay? And then it goes around again. If they answered yes to these questions and they failed, they completely need to do a referral. Okay, for services. So, for instance, for this, you can refer to early steps, or if there's concern with hearing, you can refer for a hearing evaluation. So it tells you step by step what you should do. And what, as parents, what their response, what they respond to you, it tells you exactly what to do next. For each question. So for instance, I had a family put yes, that she's ever, number 2 is that have you ever wondered if your child is deaf? She put yes. So when I did the follow-up interview, she explained how she would talk to him in front of the TV, and he was just ignoring her, and maybe the 4th or 5th time, he paid attention. He said, oh, what, mommy? He's so into the TV that he wasn't paying attention. So went through all the questions with them, and it turned out that he passed. Because he was ignoring her, not the concern with being deaf. So, any questions on scoring the initial MCAT, follow-up questions?
So, making a referral, if they still are failing, you have a follow-up interview or on that initial one where they had 8th grader, you're going to make that referral immediately if at all possible. Within that 0 to 3 or 3 to 5, it's still in early steps or fiddler's referral. Sometimes you're going to screen kids just because you have to screen them, and then the parent will notify you. Yeah, they were diagnosed with autism already. A neurologist maybe gave them a diagnosis or something along those lines. The same happens with ASD some of the time. If that diagnosis has already happened and there's already an early intervention plan in place, you do want to make sure that they're actually registered with CARD. It's the Center for Autism and Related Disabilities. Again, you can't do everything, right? So you need to utilize existing resources that are available to families and community. And CARD, links families with services, and can be educational advocates for families, and it's just a real solid service. It makes families aware of when, there's services that might be beneficial to their family, so that's important to do. Regardless of whether or not the child fails or not, if a healthcare provider, if you're working in that setting, or a parent has specific concerns about ASD, it's okay to refer them for an evaluation even if they're passing on the MCHECs. Okay. Sorry, I wrote this presentation, this part of it, for more of a pediatrician population, but, again, it's important to be honest and not minimize, well, they screen on this, but, most of the kids that get screened with this, that fail it, they're still fine. And if presenting the data, most of the kids that continue to fail the MCHAT, they're not fine. There's something that is a concern in terms of development. But along those lines, positive screen does not mean diagnosis. And again, that's why we had those kind of here's what autism is, because if you're talking about this, and parents might feel overwhelmed, you want to give them some just kind of key understanding of what autism actually is, and offering support to link them in that process. We haven't talked about this yet, but there is this idea of referral refusal, right? So how many times when you actually try and link a family to services, like, yeah, I'm good, like, I'm not, my kid's fine, I don't need these services. I'm too busy, we got too much, like, I don't have time, like, you're lucky that you get to hang out with me because I don't have time for anything else. I think that one of the things that's really important for you to do, especially if you're contractually obligated to be conducting these screenings, is we have parents sign a referral refusal form. Sometimes they're already receiving services, so it doesn't make sense to re-refer them, but just kind of documenting in some way that they have refused a service or a referral of some sort. We have a template that we use, and when we share resources, we'll provide that to y'all, and you can, make it work for your agency in any way possible. Obviously, you want to provide them with print resources if possible, but definitely if they're actually getting services already, trying to get a copy of that documentation so that you ensure, so like you were saying, linkages, making sure that handoff actually happened, and parents may say, yeah, we did something like that, but then like you're like, are you? Does that mean that it stops? I don't know. Oh, that was you? Come on! Anyways, getting a copy of that information, if at all possible, so that you know that they're actually getting services, or maybe that they're getting the intensity of services that they need, or that they're satisfied with those services. And what we know is, even though we're getting better about providing services to kids with ASD, and we're getting better about, things like Medicaid, providing reimbursement for ABA services, kind of more gold standard services, the capacity of our community to provide lots of evidence-based intervention at the intensity that these children need. There's definitely a mismatch between what they need and what they're actually getting. So we think that it's really important that we help advocate for that and recognize that the minimum that your child's getting may not be what they actually need to help them have significant, meaningful changes. That's why getting them linked with cards can be really helpful, and making sure that they're linked with early substance fittlers, as I said. So here's.
And I just wanted to add something, just like we talked about the ASQ is pretty forward with a normal limit, but parents still have concerns, we would just, trust their judgment and refer them as they request it. The same with the MCHAT. Sometimes, because it is parent interview, parent report, maybe they don't see what we see. So they can be, within the normal range, but if you would think that they would, it would be appropriate to refer them, I would definitely speak to the parent and have them go ahead and just have them checked. I've had two already. They've come out, in the low risk range, and they both had suspicions of them, and they both went and they both got diagnosed. So definitely, use your best judgment with them. And, you're the professionals, what to look for. So, just have, share that with the parents.
And even if you don't know what to look for, because you're not used to doing this, as you kind of like, if you've been doing this interview for a while, like, at first you're like, it's not automatic. You don't know exactly what to be looking for, but the more and more you administer these measures, the better you will get at kind of being very astute in terms of what it is that you have to look for. So resources, so that's just giving kind of the card resource. Actually, I think the one I have here is for Palm Beach. If you want the card one for down here, it's just going to type in University of Miami card. It's a blend between UM and Nova Southeastern. Autism Speaks has lots of great resources. The MCHAT screen that has a lot of the MCHAT forms on it. And then there's autism, the MCHAT screener on Autism Speaks as well. That will give you kind of an online report. We were at 5 out of 5. Okay, we're on the last one, home stretch. We're going to talk about depression. So we're not ending on a positive note, unfortunately. We're going to spend a little time talking about rationale, and then we'll get into the tool. How many people have to do Edinburgh postpartum depression screening? Are there people here that are not contractually obligated to provide postpartum depression screening? Should we free the ones that don't have to do Edinburgh? No? Yes, free them, or no, don't free them? All right, so if you are not doing Edinburgh screening, well, so before, I should have said this. So first, let me make sure that there are no questions that you have not wanted answered related to the things we've talked about thus far. Because if you're not doing, I mean, you will learn, and you'll learn about postpartum depression screening, why it's important, but I also want to be respectful of your time, and if this is something that like, your program is definitely not due for the next 3 years, I don't want to force you to stay here against your will. And there is someone from the trust who said that it is okay for you to leave if you are not doing this at all. Okay? And if you don't know if you're doing that or not, the contract started in August, it's now the end of October. You might want to just to find out. I don't know. You might want to go find the contract manager. I'm not sure. All right. So, if you're going to ditch, now is the time to ditch. So, this is what society might lead you to believe about parenthood, right? So for those, I mean, you see pictures of kind of happy babies, these happy families. They're so excited. You know, people post images on Facebook or Instagram about how beautiful, and you're like, hey, you know, like getting stuck with the invention of social media. Like, everyone's like, hey, vote for my baby in this baby photo contest. Like, okay, I get it. Your baby's great. Your baby's beautiful. Your baby's cute. But this might be what parenthood actually feels like, right? Like what we project outwards to the rest of society. This is one of my favorite photos of all time. I'm afraid of that baby. Right? So it's a lot of sleepless nights initially. Somebody lied to you and told you that babies sleep all the time. Or that if you just hold them, they'll automatically stop crying. Or you have a baby that's colicky. And just a lot of times maybe there's this mismatch of kind of what we expected in terms of being a parent and what it actually is. I'm going to run quickly. So did anybody serve families prenatally? Okay. So prenatally, again, one of the best predictors of depression, postpartum depression, or any depression is past episodes of depression. So if they've had any history of depression whatsoever, I don't know if you do that during your intake process, they're going to be at increased risk for prenatal depression, increased risk for postpartum depression. So this is happening during the pregnancy stage. There's crying. Sorry, not pre-pregnancy, prenatal stage. Definitely not pre-pregnancy is a whole other thing. Sorry.
Yeah. I have a question. What is
anhedonia? So that is loss of interest in pleasurable activities. So things that you used to like to do these things, and you're beginning to kind of not like those things as much anymore. You don't view them as important, or you don't make the time to do those things. All right. A lot of this could happen. So there's those pregnant mothers who are glowing, and then there are those pregnant mothers who got lied to and said that morning sickness was only going to last the first trimester, and now they're nearing the end of the second trimester, and it's not going away. Maybe potentially it was an unwanted pregnancy, or maybe their partner was there at the beginning of the pregnancy, but now they're not so sure that partner is going to be around. So a lot of different things that can play into kind of whether or not prenatal depression actually emerges. Then there's the baby blues. Okay, so this is the first couple weeks after delivery. usually the first week, peaking at day 3 through day 5. Can you imagine why the baby blues would peak at days 3 through 5? Where are the parents the first couple of days? In the hospital, right? And they'd be like, wait, legally you're going to allow me to take this child home, like, on my own, right? Or lots of people come and give lots of support initially, and then, like, they go away. They lose that social support. Or it's just kind of that adjustment period. So this could happen. This is a high prevalence rate where this happens. We're kind of, moving from, like, this pregnancy to just kind of now being a parent. There's lots of changes that are just happening in terms of making that adjustment to being a new parent during that time. Then there is postpartum depression. So this is most reliably assessed. So what we know in terms of postpartum depression is, or postpartum depressive, I'm losing my ability to speak. Postpartum depressive symptoms is that they gradually decrease over time on their own for most people. So there's kind of that spike over the first 2 months, but kind of when we're really reliably knowing that there's still a concern that it's not an adjustment period is around that 2-month mark postpartum. And the reason, the way we distinguish it beyond baby blues, that it's extending beyond kind of those initial 2 weeks. So kind of like other forms of depression, persistent sadness, poor concentration, feelings of worthlessness, like I know I'm not a good parent. There could be thoughts about the misperceptions about things like my baby doesn't like me. They could have other people that are criticizing them for all the things that they think they're doing wrong. I don't know how you distinguish insomnia from just being a new parent. I think that one of the things to consider when you're kind of looking at sleep difficulties is if the baby's sleeping in, like, let's say 3-hour intervals at night, and the parents maybe only getting 1 hour sleep, so they're having difficulty. So kind of assessing, like, what is normal versus maybe what's not so normal. Feeling completely and totally overwhelmed, poor bonding with the baby, lack of interest in kind of baby, only responding to the baby when the baby's crying. I go over this just kind of briefly to kind of put in perspective that even when we're screening, is occasionally something like this might come up, where we have, within 2 to 4 weeks after delivery, there's an increase of actually auditory and visual hallucinations or delusions, often about maybe things that there are voices that are telling them to do things to the baby. These are very high-risk situations. And I think it's something that we want to have very close, like if you see something that's going down that road, you want to have very close monitoring that. I don't know how many years ago, it was a couple of years ago, like just somewhere here in Florida where like mom put all of the kids in the minivan and like tried to throw it to the ocean like that. I don't know if that was a diagnosis, but it was probably something along those lines that might have been happening where they're having suicidal, even homicidal ideations. And hearing things about wanting to harm the infant, not being able to trust people. So, like, for those of you that are doing home visiting, they're really good initially, but then, like, they start being, accusing you of things or being very worried, or they're canceling with you, but you see that they're still there, and just kind of, I don't know, just some, it's a very low prevalence rate, but it's just something to kind of keep in the back of your mind. So in terms of just kind of broad risk factors of looking at parenting, is looking at if they have that history of mood disorders, if there's any history of substance abuse, if they've had past postpartum depression, if they haven't had depression but they have family members that have had depression. There's lots, having a baby is a financial stress, right? The cost of daycare is a mortgage payment a lot of the time. The cost of diapers, right? Cost of formula if they're not breastfeeding. The relationship between a parent and their romantic partner changes significantly, at least initially after having a child. If it's a younger mother and all of her friends are still kind of hanging out, going out on the weekend, and all of a sudden she has an infant, and it's like, Like, nobody wants to go hang out with the person that has a baby. They want to go do fun stuff, so are they losing their social support network? Just in general, just other risk factors, teenager mothers, single mothers, low income. This is none of the families we serve, right? Tobacco usage during the last trimester. I don't know why that seems to be related to postpartum depression, but now you know. So keep that in mind. There's a lot of comorbidity between anxiety and depression. So if they're anxious, that increases the likelihood of developing depression. Low self-esteem. A lot of you are, how many people are assessing parental stress? Got some folks that they're screening for parental stress this year. So looking at parenting stress and seeing if there's a correlation between parenting stress and postpartum depression. If they have a history of trauma, that could be some type of sexual assault or sexual trauma or any type of abuse as a child, adolescent, or even as an adult, that increases the likelihood of experiencing postpartum depression if they had a complicated pregnancy, which we talked about that. Now, the kiddo factor that kind of leads to that is kids that are, the parents perceive them as having a difficult temperament, infants that are born premature, if they have, if they're born with chronic illness or they have special health care needs or a genetic condition, all of those things complicate things and increases the likelihood that a child's parent would have postpartum depression. Obviously, colicky is not a fun situation. Men's health issues, dropping them in there for you just so that you have them because dudes matter too. If dad is not depressed, but mom is depressed, that can, depression can actually be contagious. It can actually increase depression in dad. If dad feels like there's an unsupportive romantic relationship, if the dad's unemployed, unable to provide for a family, same in terms of social support, vast decline in sexual relationships. That is such a shocking statement that might contribute to dad not feeling great. In our Healthy Steps programs, we do monthly parent groups, and one of the parent group talks we have is restoring intimacy after childbirth. And for some odd reason, that is the most male-attended group that we have. I'm not sure what's going on there. The other thing that's kind of neat, is that 2 to 6% of dads also experience postpartum depression. So I know contractually that we're only screening, moms. We've had dads at clinics like, hey, why aren't you screening me for that? Like, I want to be screened for that. So go ahead and do that clinically because, that also has an impact on the child. If dad is not depressed and has a nice, warm, caring, nurturing relationship with the child, that can actually buffer some of the negative impacts on the child if the mother has postpartum depression. So again, it's important to remember dads in this process too. So in terms of how it relates to parenting, negative cognitive biases of self and baby, like, I'm no good at this, I'm horrible, baby doesn't like me. When people are depressed, they tend to focus inward versus outward towards helping others, and more like, geez, I'm a mess, I need to focus on me, and when they're doing all that focusing inward, towards the parent not focusing on the child, right, or the children in the home, or the relationship with a romantic partner, and you can see how it can snowball. Misunderstanding, so like, my baby's crying, she doesn't like me, or she just cries to get attention. It's kind of misperception of what it is that's going on there. If you have a parent that's not showing any warm, positive, smiley affect to the child, that can actually impact the child's emotional development. Obviously, we talked about it affects bonding. Parents with postpartum depression, the mothers they're less likely to continue on for breastfeeding. They're only responding to their children when it's needed. There's less physical touch. We know how important physical touch is to children early on. It can actually cause them to actually begin to engage in withdrawal or isolating type behaviors. Here's where, how many of you got to do the home safety checklist? Right? We got some of those in the room. So parents with postpartum depression, this is kind of a red flag for you, right? Is that they're actually less likely to use child safety devices. They're less likely to use they're more likely to use incorrect use of kind of setting a child care seat, child care seat? Oh my goodness, child car seat, and not having it in the correct positioning. They're more likely to put their child in an incorrect sleeping position, so increasing the risk for SIDS. They're less likely to use a safe water temperature because they're so focused on them, they're not focusing on being in tune with what their child needs in that moment. They're also more likely to use the ER, so just think about from a societal cost, if you're not getting primary care services, that kids are not getting immunized on a regular basis to the same degree. And this is why it's so important, right? So there's a safety issue, but also impacts kids in a negative way if we don't catch this and help with this. Is these kids, if there's chronic postpartum depression, it impacts the children's, on average, their cognitive ability, their core language skills, because parents not really talking to them, emotional development. So you see, like, all of these things that we're focusing on or screening for, trying to promote within our parenting programs, we're seeing negative outcomes. We know that I talked about the importance of emotional regulation. If the child is very disoriented in terms of regulate or who the child can expect to help with regulating, or the parent doesn't foster a positive way of helping the child, learn kind of a tiered approach to learning how to regulate over time, it's going to contribute to that. It can contribute to infant sleep difficulties, which some of you, after eating cookies, you would have no difficulties going to sleep right now. Is that infant sleep difficulties is actually predictive of future behavior problems, right? And it can also impact, I don't know why these things are, but it can actually impact child growth, maybe from a nutritional standpoint, and these kids are at increased risk for cardiovascular GI issues. So it's a huge problem. So that these are things that, this is why it's important. This is why I think the trust put it forward to include this in the programs. In all of these risk factors, I also do work in the child abuse field. There are also risk factors for child maltreatment. And we know that kids under the one are the most vulnerable for experiencing child maltreatment. So we want to keep that in mind because if there's postpartum depression in place, they're at increase for all different forms of child maltreatment. All right, so everybody's really happy now, good to go, it's not a problem. Can have this really negative, and this is why I just wanted to put it in context. I feel like sometimes when we give parents measures, we're just kind of checking a box because that's something we have to do for a contract, and we don't think about clinically how meaningful it is. And again, we're going to talk about it. It's a very safe, valid tool. If the parents are telling you that they're depressed on this, they want you to know that they're depressed. If they want to fake good of it, it's very easy to do, you won't know. So the people that are actually scoring high on this, they're really letting you know on some level that they want to be able to talk to somebody about it, or that they're letting you know, hey, I need help with this. So you're all screening, so I don't need to tell you on why we screen. Historically, it's been done during follow-up visits at their OBGYN when they go back for their 6 to 8 week follow-up, or pediatricians that even that's being done at a variable rate. So I think that's pretty cool that across a large number of providers we're going to be doing this. I think that's helpful. But there are some concerns about doing this, right, from an agency perspective. We do parenting. We don't do like suicide stuff like that. That's not our specialty, right? I didn't get any training on suicide prevention or anything of that sort. There's the whole thing of, well, if I screen them and if they screen negative and then they go and kill themselves, is my agency going to get shut down? Am I going to get sued? So we'll talk about some of those parameters and kind of, how many of you, when you serve a family, the chart is under the child's name? Anybody, or does everyone have it under the parent's name? Parent? Okay. Okay, so that makes it a little bit easier. If it's under the child's name and you're putting a parent screening measure in there, and then there's a custody dispute someday, and one of the parents subpoenas the child's records, and if there's a custody battle going on, well, look, the mother clearly has mental health problems. Look at the screening results, so things of that sort. And also, as parents, I think, are more willing to do things to help their children than they are willing to help themselves. But that's why I gave you all those rationales of why it's important to help parents with this, because if they help themselves with this, they're really helping their child across a number of different domains. And that's why I wanted you to have that information so that you can communicate that to parents as well. Also, our kids have insurance, generally speaking. How many of our parents have insurance? Right? That's a lot more variable. So giving that to providers is something that is tricky. So when we do the systematic screening, kind of like everyone else, it's more timely screening, more timely referrals. We take out that clinical judgment out of it. We know that early childhood is a critical period. We've been talking about that at length forever today. And we know that early intervention is going to be more effective. I should have corrected this from yesterday. It's Edinburgh with an H, but I mean the H is silent, so who really cares, right? It's a quick 10-question item, and they have the Edinburgh as well. Yes, okay. It's open source. It's available in English. It's available in Spanish. I'm going to let. Don't worry about the possible risk. You guys just be worried about 10 plus. So.
So our last measure, right? Okay, so this, again, moms or dads, since we brought up dads, can fill this out. It can be done interview style also. So the scores also go from 0 to 3. On some questions, you'll see that the scores are reversed. Okay? So parents, the caregivers, moms usually fill this out themselves. The questions 3, 5, 6, 7, 8, 9, 10 are reversed. Question 10 is the question on have they ever thought of harming themselves. Okay?
So essentially, when they fill it out, when they fill it out, and they have it in front of them, is when they fill it out, essentially you're just going to take it and add all of the items, right, to get a total score. And if the total score is, what is this one? If it's 10 or more, then that indicates that the mother is at risk for postpartum depression. Right? Again, if you look at these items, they're pretty face valid. Like if they don't want you to know, it's pretty easy to fake good on this one. Okay, so I think that when you get those 10 and above, you really should take it seriously. And then the tricky part is really thinking about who are we going to link these families to? Where are they going to go to? And we've been doing this now for maybe not 5 years, maybe like 3 to 4 years. And we have not solved this problem, so we'd love to hear what other. So oftentimes we're referring mothers back to the primary care provider, referring them back to OBGYNs to discuss medication options. We're trying to link them to behavioral health providers, but that's really variable. Even if they have medical insurance, oftentimes that the mental health carve out of what they have is a really high copay, which makes it really difficult for them. I don't know where else you refer. Where are other places that you guys refer or you know that provide postpartum depression?
You have groups at UM at the hospital.
They used to have groups at Jackson. I don't know if they still do or not. They still do? They used to, and then it got defunded.
This is a hard one. So, the score 10 or greater, or number 10, if they indicate anything else than 0.
And I think here's what, because there's lots of providers that are going to be doing this, and my understanding is that the trust is really trying to make a big push for capacity building in the areas that we need. So we've been begging for 3 years for more capacity building, or we're like trying to create more of a network of providers in the community, but I think we're in a much larger way. So the screening, I feel like, is really that first step. And I think when I hear that there's not enough resources for these families, I think we'll see a change in that direction as well. But it's not going to be easy. And it's not as simple as, your ASQ referral to early steps, that's a good safety net, right? It's going to catch everyone as long as they go to the appointment. This one is a little bit more difficult to get families to actually get to go. Okay? The other part is if they answer anything other than a 0 on question 10, that requires some additional questioning. You've got to ask more about that, right? Because without harming myself, so you're asking them specifically about how they felt in the past 7 days, so in the past week. So the thought of harming myself has occurred to me. Hardly ever still means that hardly ever was in the past 7 days. Okay? So that's a concern, right? We're now concerned about the parent safety. We're now concerned about the child's safety. So that's something to take into consideration.
Yes. The question is also with, for example, in my case with teenage parents, do you contact the mother of the teenager, and then you have to make them write a consent? That you have to share the information with someone else besides them?
There is some clinical judgment that goes into this, and I think that each agency has to develop their own policies and procedures as it relates to this. This right here kind of gives you some steps to think through in terms of what to do if somebody does screen positive on item 10, where you have some concerns about that. But I do think that things that you have to think through as an agency, right, because part of our partners are trying to make sure that these children are safe. If we have concerns about if the parent's actually going to harm themselves, are we obligated to call DCF in that instance? If it's a teenage mother, do we need to make sure that there's another person that can keep an eye out on the, like what natural supports that we can bring in that can increase the monitoring of this family? Are they at the point where if you say, yeah, I've been thinking about it, like, I've been thinking about just driving off a bridge, like, they're simply saying that they actually have a plan. They tell you that they have a plan. Like, that's really concerning, right? So you're at a much higher level in terms of what it is that you have to do. This is a very commonly used patient safety plan template. Literally, if you Google patient safety plan template, like it's like the first 4 or 5 responses. What it is, and it's good for our families to think about it, so that anything other than item 10, in our case, if that happens, they have to consult the supervisor, and the supervisor and the staff member have to come to an agreement on kind of what are the next best steps in the situations. It's regardless of, even if you don't have a supervisor available for it, that you want to consult with somebody else, get someone else's opinion on this in terms of how you feel like it's best to proceed. Because making these decisions alone, on your own, can be pretty stressful. And just kind of bouncing off ideas. And there's always some interesting variant to it, right? Because even if they feel really suicidal, they're like, okay, what are they going to do with the child, right? So if you say, hey, you really need to go to a psychiatric hospital or a mental health hospital and be evaluated further, like, yeah, I can't do that because of my child, but then, like, if you let them go home and their child's left unattended, then now you're talking essentially 2 lives, right? So it's not an easy decision to make. This isn't like to freak you out or anything, but it's more just kind of think through what do you need to take back to your agency and think through it more in detail. So when you're working through it, you decide, to come up with a safety plan. I always like having things written down, right, documented. It's helping them, identify what are those triggers, so thoughts, images, mood, situations that let me know that things are getting not so good for myself. A lot of our parents don't have great coping strategies, but they probably have some coping strategies that do work for them. So having them identify, Maybe it's listening to music, maybe it's going for a walk, whatever it is, have them writing that down in terms of coping strategies that help them feel better when those triggers happen. What are some natural supports, people that can help distract me? So like if the source of a lot of this distress is a partner, a romantic partner, can I call my mom? Can I call somebody that will take my mind? Or can I call somebody to go grocery shopping that will take my mind off it? And then kind of thinking, who are the natural supports? So if I get to the point where I'm not really feeling safe, like who are some natural supports? So is it a family member? Is it a friend? Who are these people that you call and ask for help that you know that they will have your best interests in mind? And then it kind of goes up to that higher level of like, who are the clinical people? And maybe your name's going in there, but maybe your program does not have an on-call service. So you have to make it clear, like, hey, yeah, you can call, but I may not be immediately available. Is it a primary care physician? If they have a psychiatrist, is it them? Urgent care center is really like, at worst case scenario, do you need to go to an ER? Do you need to go check out a mental health? And then you also have a suicide prevention line also put in there as well. And then are there things that we can do that could make the environment safe, right? So, I don't know, mom's like, hey, I had a C-section, so I still have some Percocet. I'm not in a good spot. Can we have dad lock up the drugs and dad be the one that, is giving up the meds when they're indicated? Or if it's a teenage mom that lives at home with her parents still, and just saying, well, I just get a knife and cut myself, and we have the parents, put, things up. This is where we get into the issues of confidentiality within behavioral health systems. We have the duty to protect the parent from harm, but we also have the duty to protect others from harm, so we have to take that into consideration. So what environmental factors can we have that come into play? And then the one thing that's most important to me and worth living for is having them establish what that is. And we'll go through that process, and what I like to do is, it's like contracting with them, right? Is have them sign off, and then you sign off, and then, if possible, and make a copy of it if you're out in the field, maybe take a picture of it, get phone, so that you have it in some way. And obviously, these are the families, as you get to this point, it's not so that if you feel like it's not to the point where they require hospitalization, these are the families you definitely need to follow up with, pretty regularly, making sure that they're getting linked or trying to get linked to a service. If you feel like they're like, yeah, I'm not doing any of that, I can't do that, and you really are uncertain about the parent's ability to keep the child safe, it's a matter of, are you calling DCF, do you need to call 911, things of that sort. Okay. We've been doing this for a long time. I think that we've only been doing it for 1 or 2 parents to the point of hospitalization. So usually you're able to deal with it more at this level, but you don't know. So just trying to prepare you for all of those different options and what could happen. Questions on that? Yes.
I just wanted to increase awareness. Now, that they have, we don't specialize in it, and I don't like to minimize mental health, but I'm a promoter. So they have a mental health first aid campaign that's going out.
Yeah. Okay. Yeah. I have heard of that, and that is more about responding to crisis situations, right?
And everybody, that's the message that they send out often like the car mark. And since we have conflict that's related to the, correlation and something that's related to something. And so that is safe and sorry and liability and all that ethics, and those people, they do have that lifeline to support the police on the street. It could be their mother, and anybody can react and say, I'm going to help you out. So that goodwill citizen mentality is always.
Absolutely. That's our broadest network, right? Yes. Yes, absolutely. Thank you for bringing that up. I have heard that that's making its way down here. Other thoughts or resources for things that people are now scared to death of? We're all doing so well, and then everyone is now sad, or they just want to get out of here. Obviously, again, you're trying to make that referral in a linkage process. If they are already receiving services, or they are saying, no, I can't do this, again, I would say that you need to get a referral refusal form given the liability issues. I think, do you have a question?
Yeah. What is the time again? Because I'm not clear.
Okay. So I think that they have it written in the contract that 6 to 8 weeks postpartum is generally when they want it administered. And that it's really meant to be specific to, the other thing is, so, for example, if you have a parent with a 2-year-old and the 2-year-old is the identified child, but the parent has another child, that when that child gets 6 to 8 weeks, you would still administer the Edinburgh at that point in time, because even though it's not the target child or the registered child, it still is important to get that completed. Yep. So signing those releases so that you can communicate to whoever you're referring out to, and following up with the agency. How many of you, when you try and refer somebody to get any type of mental health services, that they're able to get in right away, unless you're being hospitalized? It's usually a wait list, right? So even talking about things that they can do to alleviate some of their depression, accessing some of those natural supports. Behavioral activation is very simple, so just getting them to do more things can help alleviate some depressive symptoms. I think that's really important. So just when looking at our own data, we look at a set of our data, we screened 363 families. We had a really low rate of people actually screening positive. Other studies have shown kind of a 15 to 20% threshold in terms of folks that were screened positive. Ours was actually under 10%. And then when we had to refer people, still not a great referral acceptance rate, because we had 7 that actually refused referrals. That was because they were families that already had pre-existing depression that had either been identified prenatally or something that's just maybe been a lifelong issue that they've been dealing with. But only had 2, so less than 10% that was absolutely refusing referrals, which is kind of surprising. But that's something that's kind of taken to point. Based on research, mothers tend to prefer therapy over medication. However, medication is most commonly used. There's always issues as it relates to child care, transportation, especially during the newborn phase, insurance barriers, and then like, I should be happy, I shouldn't need to go for postpartum depression services. Lots of different kinds of approach. Peer support feels like that kind of maybe calls to mental health first aid. Health visitor approaches, non-direct counseling, interpersonal psychotherapy works, CBT works. Most therapies, when they're looked at, they're pretty good at reducing depressive symptoms, so like it works. It's not great about maintaining those changes. So again, best predictor of a future depressive episode is a past depressive episode. High recurrence rates. Support groups may not be well attended if we have those. But even when we provide these interventions with people with various level of training, they still seem to work. But again, with this population, there's high attrition rates. All right, lots of meds that can help. In terms of the meds listed here, there's some that are listed as kind of being best evidence-based for use in breastfeeding women, where they had minimal to limited to no side effects. In terms of those evidence, that there's been no long-term data that's been published, kind of looking at the effects. I'll give you a good resource for that. But just kind of take-home points for all this. We're nearing the finish line. Is risk factors for postpartum depression, child maltreatment are similar. We're placing kids at long-term risk for kind of all kinds of bad child outcomes, including child maltreatment. Dads matter in that process. A long way to go, kind of how we improve our screening and linking process. But again, we're all going to be in this together, and I think we'll be able to kind of move things in the right direction within our community. But we probably need more long-term monitoring. So for those of you who have longer durations, you may want to recheck and screen later on to see if things There is, and I guess someone at our training yesterday actually said that this drug, Developmental, is actually, I think it's actually an app now, so people can have it on their smartphone, they can look up meds, see if there's any interaction between that particular medication and breastfeeding. And then there's some online resources that kind of, ramping up to provide support for dealing with postpartum depression. And we got done 17 minutes quicker than we did